Good morning, everyone. This is Carol Razzo from Elderwerks, and we're delighted to have all of you on this morning. Today, we're going to be hearing from our training specialist and nurse with Elderwerks, and that's Chris Petrik, and she's going to talk about and present living with arthritis. We'll be recording this. It also will be on Facebook Live during the session. In addition to that, just a little bit about Elderwerks. As you probably know, we are always here to advocate and assist. We help seniors, families, and professionals finding any kind of services that you need. We are experts in senior housing, in addition to caregivers coming in, medical and non-medical. We work with several elder law attorney firms, and of course, we do a lot of education. As you probably know, we have an office in Palatine. Right now, nobody's going to too many places, but we're always there. If you need to have a meeting in person, just call us. My contact information is here, and our phone number direct at the office is 847-462-0885. So Chris, I'm going to turn it over to you. If everybody will be sure that they mute their information throughout the presentation at this point, we'd appreciate it. Chris, thanks so much.
Thank you. Thank you for having me. Hi, everyone. I'll just give you a little background, and then I'm going to ask if everybody mutes and takes the, take their stop their video so everybody can see the whole screen. Like Carol said, my name is Chris Petrik. I'm a nurse, and I also work for Elderwerks as their training specialist. I am a certified dementia practitioner and a certified dementia instructor. Welcome to our seminar or webinar, whatever we want to call it, on Ask the Nurse. We meet every second Thursday of the month, and we talk about topics that either the last audience has requested, or I always have something ready in my back pocket if I don't get any requests. So if you're here today as a first timer, if you're here today and you've been to our Ask the Nurse before, welcome back. If you have any questions on anything that we talk about, we're going to ask you to save those till the end. And if there is a topic you would like me to address in the coming months, I will be happy to do that. Just go ahead and put that in the chat. So right now I'm going to stop my video, and I'll ask everybody else to do the same. Thank you. And we'll begin our talk on when Arthur comes to visit. Maybe you might wonder what this has to do with arthritis. And both my parents had arthritis. They had osteoarthritis. It's just, and we'll talk about that in the upcoming minutes, but I used to call home after I left home and ask how mom and dad were doing. And if they were having a bad day with their arthritis, they would say, "Oh, Arthur's visiting today." And I told him that although he can visit with me for a short while, I want to make his stay short. So they always had the upside of things in life, and that was one of the things they said was, "Arthur's here today to visit," or "I'm feeling good. Arthur hasn't stopped by in a few days." So if their arthritis was kind of they weren't feeling too much pain. So I'm going to talk about arthritis today. We'll talk about what it is and how it happens and some of the treatments for it. In doing my research, I did find that there's over 100 types of arthritis out there. And so obviously in 30 minutes, we won't have time to talk about that. So I'm going to talk about the couple that most commonly affects people. And then we'll kind of open it up for discussion after that. So the first one we'll start with is rheumatoid arthritis. Rheumatoid arthritis is considered an autoimmune disease. Symptoms include fever, fatigue, loss of appetite, joint pain, swelling, and stiffness. It affects joints symmetrically, meaning it can cause swelling in pairs of joints on both sides of the body. Particularly, you're looking at smaller joints such as both hands and ankles. Generally, it's worse in the morning after long periods of rest or lack of activity. And it can occur at any age, but usually 30 to 60 years of age in women and later in men. It affects 1.5 million people in the United States. There is a form of rheumatoid arthritis called juvenile rheumatoid arthritis, and that occurs in the preteen, early teen, and young adult age. And you know, as I was doing this, I was reflecting back on some of the friends that I had when I was younger. And I remember this particular male friend of our group who was fine one day and couldn't get out of bed the next day. And, you know, day after day, he had, you know, recurring pain, and he finally got diagnosed with juvenile rheumatoid arthritis. And so, although it usually occurs at 30 to 60 years of age, again, I want to mention that there's a form of rheumatoid arthritis that affects the younger population, and that's called juvenile rheumatoid arthritis. This is difficult to diagnose, and we'll talk about diagnosis more in a bit. It's difficult to diagnose because of the pain and the symptoms in the early stages really mimic those of other diseases. The doctor will check, you know, typically you'll go to the doctor and you'll complain of joint pain, and they'll look at joint and swelling and redness and warmth in those joints. So that is rheumatoid arthritis. The next one is osteoarthritis, and osteoarthritis is probably what more people in our age group suffer from, and you can see at the bottom of the screen it says it affects 27 million people in the United States. It affects only the joints that can be caused by factors such as weight, overuse, and injury. So any of those joints that are overused, we will see arthritis in those joints. I just had a conversation with my daughter last evening. We were just, you know, chit-chatting, and she has arthritis, and she had just recently been to the doctor. She's going to be 43. And or 42, I'm sorry, making her older than she is, but she has arthritis in her hips and her knees. However, she played soccer up until last year, so it's a lot of wear and tear on the joints. She's a runner, she's run marathons, and while all these exercises keep us healthy and we need to exercise, the overuse of those particular joints is where our osteoarthritis is caused. The symptoms include joint pain, stiffness, and a decreased range of motion. It may not affect both sides of the body and can affect joints such as back, hip, neck, or knees, small finger joints, and big toes. It tends to get worse throughout the day from activity. And that's counterintuitive what I'm going to tell you about treatment, and it affects people later in life, usually people 65 and older. But, you know, my daughter is probably that perfect example who overdid the activity and so is now suffering from arthritis at an earlier age. And again, it affects 27 million people in the United States. And again, we're going to talk about osteoarthritis and rheumatoid arthritis treatments in a minute. What I did, and if anybody wants a copy of this, Emily can just cut this out of the PowerPoint and send this off to you. What I did was I created a table and gave you what the type of disease it was, and you know, what is autoimmune, what is not autoimmune, symptoms, and locations, time of day, age of onset, and the prevalence, just so you can compare and say, is it osteoarthritis that I have? Is it rheumatoid arthritis? And again, we'll talk about diagnosis of those. You know, the one thing that we know about rheumatoid arthritis and osteoarthritis is we know that osteoarthritis has a familial tendency, which means that if your parents have arthritis, osteoarthritis, because you have very similar DNA, and if you are as active or non-active as they are, you may have arthritis yourself. So like I said, both my parents had osteoarthritis. I also have osteoarthritis. I have it in my knee, my left knee, and I've already had a hip replacement on my left side because of osteoarthritis. And we'll talk about replacement and just really when it's necessary. If you can see the symptoms side by side, you'll see that there's fatigue and fever with the autoimmune part of the disease, which is rheumatoid, different where you won't see that in osteoarthritis. You'll see a decreased range of motion, and that's really because of the stiffness and the joint pain. And again, just looking at them side by side, we know that the autoimmune rheumatoid arthritis, again, is more symmetrical, and where osteoarthritis can affect different parts of the body. And again, whoops, I'm sorry, generally worse in the morning for rheumatoid, and osteo generally gets worse throughout the day from activity. And I do have to say, I pulled some of this information, and this one was right from the Arthritis Foundation, and yet, for myself and for other people that I've talked to, I tend to disagree with that, and I think maybe it's just a personal thing. Getting moving for me and for others, I find that my arthritis is worse in the morning when I wake up. I'm a little stiffer, but I feel a little bit better during the day. Of course, when it's at that severe point, when you have that later stage of osteoarthritis where you're bone on bone, you do feel miserable most of the day. And then comparatively, you can see the age of onset for both of those populations and the prevalence on both. So again, if you want a copy of this, just for your own reference, please put your email in the chat, and Emily will go ahead and send this to you. This next one is psoriatic arthritis, and that's a chronic inflammatory disease that affects about 30% of the people who already have psoriasis or a chronic skin disease. It occurs when your immune system mistakenly starts attacking healthy joints and skin. The faulty immune response causes inflammation that can trigger that joint pain, stiffness, swelling, as well as red, scaly skin and patches that we call plaques. So you'll hear it as plaque psoriasis or just psoriasis, but the arthritic autoimmune form of that is called psoriatic arthritis. Now the symptoms are going to vary from person to person. It affects the skin and the joints. We will see those red scaly patches on any part of your body, and those are called plaques. The joint tenderness, swelling, you'll see pitting of the nails or separation of the nail from the nail bed, pain and stiffness in the neck and lower back, morning stiffness, reduction in your range of motion, painful sausage-like swelling in your fingers and on the toes. There may be a family history of autoimmune disease. It's higher in people who are smokers, and you'll see a history of it with plaque psoriasis. So, it really affects all ages, and you see a lot of it affecting the younger population. My youngest son is in his mid to late 30s, excuse me, and he has a friend who's a health nut and started developing psoriasis and got treated for that. And within a year, he was completely incapacitated from the psoriatic arthritis. He wasn't able to, he lives in Colorado, he wasn't able to hike and bike and do and he'd become a father, he wasn't able to play with his child. So it can be a very devastating disease. Once they got him on medication, it made a world of difference. So it can go to being very mild, and that's the reason I bring this up. It can go be mild to really devastating to a person's activity of daily living. And once you start, noticing those plaques, you really need to see a dermatologist to have that evaluated, and then, see see a rheumatologist, because it very well could spin into the psoriatic arthritis. This is kind of interesting. There's something called thumb arthritis. And again, just relating this to a personal experience, my husband, who's about 6 years older than me, started complaining of his thumb hurting. It looked maybe a little bit swollen, but he woke up every morning and it really hurt. And because I'm a nurse, I told him what to do, and we tried all these things. And as I'm doing my research, because I don't know everything about everything, I found this, and I'm like, you know what, you have thumb arthritis, because nothing else in his body hurts except his left thumb. And he noticed that when he was opening jars, it hurt, and the range of motion in the thumb was difficult, and he felt weak. And again, we'll talk about treatment of that. So there is one specific just for the thumb. And then there's gout. And gout is a common form of arthritis that affects joints, but most often the joint at the base of the big toes. It's caused by a collection of urate crystals that accumulate in the affected joint. Signs and symptoms include joint pain, lingering discomfort, inflammation and redness, warmth, and limited range of motion. Now, I have been in healthcare about 40 years. So I have worked in the hospital at the time where they used to admit you for everything. And I can remember, I worked on a rehab unit, and I can remember several patients who came in with gout. They used to admit you for that, believe it or not. Although I've never had this experience, I've never had this experience, I can tell you there is, and anybody out there who's had gout will tell you there is significant pain when you're experiencing a gout flare-up. So again, a different type of arthritis. It's in that arthritis family. So how is arthritis diagnosed? It depends on what type of arthritis you have and your symptoms. But the first thing that you do is you probably will go to your primary and give them your symptoms. They may be able to delineate from your symptoms what kind of arthritis you might have just by asking those questions. Is it symmetrical? Do you have a fever? Are the joints warm to touch? Things like that. So they'll do a physical exam. If warranted, if they think that it might be rheumatoid arthritis, they may do a couple of lab values. And they might do something called an RF, which is a rheumatoid factor, an ANA nuclear antibody, which is something that we look at. It's a level of the antibodies for autoimmune diseases such as arthritis. Uric acid levels, they'll look at that for gout. And the other ones that they may look at is your what's called your SED rate, your erythrocyte sedimentation rate, or your SED rate, and your C-reactive protein. Both the SED rate and the C-reactive protein, or the CRP, are indicators of inflammation in your body. So it doesn't narrow it down. I have an autoimmune disease called polymyalgia rheumatica, and they were able to diagnose that with the SED rate and the C-reactive protein. I guess not diagnose it, but they were able to rule in and rule things out because both my SED rate and my CRP were elevated. And that means that I had some type of an inflammatory process going on in my body. So it narrows things down, but it's not it's not exactly diagnostic, should I say. It just looks for inflammation in your body. So they may do that. You may not necessarily have, with osteoarthritis, you may not have high levels in your SED rate and your CRP, but you probably would have that with rheumatoid arthritis. But again, not a diagnostic tool, just kind of rules things in and out, because you'll see it in other autoimmune diseases. So again, just some of the lab tests that they may do. They may do an x-ray, and they can look for, you know, a little bit of bone changes in the x-rays. They can look at, excuse me, the severity of your bone changes or your osteoarthritis on MRIs. For example, if you're having a lot of arthritic issues in your knees, they may do an MRI and just rule out that it might be, you know, maybe a soft tissue, a ligament or something else, but they're in the x-ray and in the MRI, they're actually going to see if you have osteoarthritis. They're going to see that bone on bone. So if you go to the doctor and he says you're bone on bone, that means that you're at a point where something may need to be done. So someone had asked, had sent me an email, or sent an email in through Emily, and asked about a DEXA scan. And is a DEXA scan good for identifying bone problems? And the answer to that is they really measure the tiny reduction in bone density. So it really doesn't diagnose diagnoses osteoporosis or a thinning in the bones in early stages. However, if it's done on people with advanced osteoarthritis, such as in the spine, but not in the hip, it can appear, the DEXA scan can appear to have higher levels of bone loss because of the presence of bone spurs. So those bone spurs must show up different in the DEXA scan. So again, it's not a particularly useful diagnostic tool, although in early stages it may be helpful. But I do have to say it's not a traditional, really the things that I have posted here, seeing your primary or your rheumatologist, a physical exam, your lab values, your x-rays, and really evaluating your signs and symptoms are really how arthritis is going to be diagnosed. So let's talk about our treatments. It really depends on the type of arthritis you have. It is rheumatoid arthritis can be treated by analgesics, which is Tylenol. NSAIDs are your non-steroidal anti-inflammatories, other steroids, and other medications. The other medications, and you've seen all these commercials on TV, as Humira, Enbrel, and these are, there's two different, another one is Xeljanz. And Enbrel is what they call a tumor necrosing factor medication, because it blocks and reduces the effect of substance in the body that causes the inflammation. So it doesn't, there is no, I want to say there is no cure for any of these diseases, but what it does is it reduces the inflammation. And then there is another medication which is used, and those are biologics. And biologics are really imprints of DNA. So, they're looking at DNA and then they're imprinting it and putting it into a medication. And again, whether it's a tumor necrosing factor, a TNF, or a medication like Xeljanz, both of them are going to do basically the same thing. They're going to try to stop the inflammation from occurring to reduce your inflammation. Osteoarthritis, on the other hand, typically is treated with just NSAIDs, non-steroidal anti-inflammatories or analgesics. And, the thought one of the things that I'm probably going to do in one of my next topics is what is the difference between all these over-the-counter medications, you know, these pain relievers, and what do they do, and what's the difference? So I will tell you analgesics, and that would be your Tylenol, is really something that increases your pain threshold. That's really all it does. So it increases your pain threshold, so you're not feeling the pain as much. Okay, it does nothing to reduce the inflammation. That's why it works for some people and it doesn't work for others. It depends on how your body reacts to those. I can take a Tylenol and it really doesn't do a whole lot for me. Okay, and there are arthritis forms of Tylenol, and all that really is a higher dose of Tylenol. The NSAIDs are different. The non-steroidal, anti-inflammatories are different because they actually work on the inflammation. Okay. But both of them, whether they're analgesics or NSAIDs, you have to be careful. Analgesics have a lifetime amount of medication that you can take of that, and hopefully you won't reach that. Excuse me, I'm having an issue with my throat this morning. But analgesics are good because they're a little kinder to your stomach. They're not so nice to your liver. So again, with any medication, you have to be careful how you take them. NSAIDs work a little better for some people, not everybody, but because they are a non-steroidal anti-inflammatory, they tend to work better because they're reducing that inflammation. However, they cause a lot of havoc on your GI tract. I know of people who have been admitted to the hospital because they're having GI bleeding. They're either vomiting blood or they have blood in their stools. And when you do a history on them, they're taking NSAIDs every day without any break. And so that's not a good thing. So you really have to look at your over-the-counter medications and talk to your doctor also and find out what is the best treatment for you for the type of arthritis that you have. For osteoarthritis, you're not going to be on the biologics, or you're not going to be on the TNFs. Those are not appropriate for osteoarthritis. You'll probably look at what we call alternative therapies, which I'll talk about in a minute, and those NSAIDs or analgesics. So again, that's a good conversation to have with your physician. In addition to that, there's things such as menthol or capsaicin creams. I want to talk about capsaicin a little bit. And capsaicin comes from the chili pepper, and it has a really surprising role in the medical field that it blocks. It's usually done topically, so it's a cream. And what it does is it blocks the nerve receptors near that joint. So because my husband had this thumb arthritis, I went and got this capsaicin cream. You can get it he got it at Costco. And it said use a small amount on the joint. So he rubbed it in. He did that right before he went to sleep at night. And he woke up in the morning and it's still he had a burning feeling at that joint. So we tried a second dose and we used just a minuscule amount of it and rubbed it in, and it did give him some relief. So it may work for some people, it may not work for others. He wasn't that impressed but he's a try once, and if it doesn't work, I don't want to ever use it again. And with a lot of these treatments, you have to try them more than once or twice. So again, there's a lot of literature written on this capsaicin, and my only recommendation is that if you're going to use it, it has to be done you have to use it gingerly. Use ice or heat for either osteoarthritis or rheumatoid arthritis, and it really is what makes you feel better. I'll tell you what heat does. It brings more circulation to that area. So some people will feel a sense of relief and they'll be able to relax with the heat. And some people like ice, and ice, what ice does is it reduces the inflammation. So, you know, let's say your ice, you know, you have osteoarthritis in your knee, you're probably going to get better results from ice than you would heat in that particular area. But again, you need to experiment a little bit. Ice should be 20-20. It's 20 minutes on, 20 minutes off. What some people do is they sit and they ice and they leave it there for an hour. It really doesn't do any good after a certain amount of time. You have to take that ice off and let it rest a little bit. So again, you know, you have to do what's best for you, but you can experiment with both of those. The other thing is be careful with that heat, because if it's on directly too long on that body part, it could burn the skin. So you know, think logically about it. Diet and exercise are very important, and I know many people don't want to hear that exercise is important, but exercise is extremely important for people who have arthritis. And the two that the American Rheumatology Foundation recommends is walking and swimming. And not, you know, you don't want to do swimming where you're, you know, on a swim team swimming. You want to do gentle movements in the water. So joining a arthritis or what they call a low impact group at a community center. I know Northwest Community has one. I know Arlington Heights. I go to the low impact aerobic exercise at Arlington when we weren't in lockdown. I did for a while until our rates went up, COVID. I was going to Arlington, the center there, because you can make an appointment and they only allow so many people in their warm water therapy pool, and they have a warm water therapy pool there, and they only allow so many people in. And I just did some water walking, and I did some exercises that I remember from doing my aerobics class, my water aerobics class. So it's really good movement, because it doesn't put extra pressure on the joints when you're doing that. And I'll tell you, I felt wonderful when I got out of there. My range of motion was better. I felt just better from head to toe. I felt more clear-headed. So as soon as I can get back in the water, I'm going to do that. But again, exercise is extremely important. Diet also is important, and you have to look at what you're eating. And you know, we don't have enough time to go into diets, but you really need to look at what's called the anti-inflammatory diet. And really, anti-inflammatory diet is looking at things like red meat, you know, refined sugars, high carbohydrates. So you really need to start looking at what you're eating. And if you're eating a lot of prepared foods, if you're eating a lot of red meats, if you're eating a lot of foods that have a lot of carbs in them, you're not doing yourself a favor, because that aids in the inflammatory process in your body. And so you start looking at what you're eating, because that is also extremely important. And so take a look at that. So those are some of the treatments and some things that you can do for your arthritis if you have those. You can go to the Arthritis Foundation and look at that and see you know, what they suggest. And also do yourself a favor and look up an inflammatory diet. Now, I'm going to tell you, the inflammatory diet itself is pretty restrictive. I tried following just the inflammatory diet, and it's hard. It is hard. But what I did was I picked and chose from that. And I pulled out some of those foods that probably weren't the healthiest for me and replaced those. And then the last thing is you've got to increase your fluid intake, and that is really looking at your water. Increase your water intake, because you want to lubricate those joints as much as you can. And keeping your body well hydrated is one of the ways to do that. So that's really it on when Arthur comes to visit. If you have any questions or comments, feel free to post those now. If you, you know, have a topic for next time, let me take a look at these questions here. I agree. So Mary says, I agree. My joint aches are worse in the morning. And that's because we've been immobile all night. And although my knees do tend to get worse when I've been on my feet too long, and that is also true. So it does have that yin and yang for those people with osteoarthritis. And Mary, yes, psoriatic arthritis is considered an autoimmune disease. And yes, we talked about how the diet, inflammatory diet is suggested for any autoimmune disease, not just arthritis, because autoimmune diseases almost always have an inflammatory factor. You look at Crohn's, which is an autoimmune disease, and there's inflammation. You look at MS, and that's an autoimmune disease, and there's inflammation in the body. So yes, anti-inflammatory diet is suggested. But again, it's pretty strict. I know someone who went on it. She had an autoimmune disease. She had, I think it was Kawasaki's disease, and she strictly went on it, and she said she has never felt better. But again, doesn't go out to eat, doesn't eat food at other people's houses. So yes, it is very restrictive. And osteoarthritis is not an autoimmune disease. It's really more a familial. So you may get it because your parents or someone else in your family, you know, there might be a history in your family, and also because of the overuse of those joints. And so, you know, again, I used my daughter as an example for that. So had she stopped playing soccer in her teens and college, when most people do, she probably wouldn't be in this pickle, but she loved her soccer. And so, you know, now she's looking at hip replacement before the age of 60. So again, you know, you got to think about those things. But when you're young and infallible, you don't think of that. So where do you find out more about the diet? Just Google it. That's what I did. I just typed in inflammatory, anti-inflammatory diet, and there were a lot of sources. There were a lot of sources in there. So again, you can pick and choose from that what you want. Any other questions or comments? Any suggestions for next time? Because if not, February is American Heart Month, and so I'll be talking about heart disease, prevention of heart disease, and treatment for heart disease in our next meeting that we meet the second Thursday of February. Otherwise, everybody have a wonderful day, and I'll bring it back to Carol. Thanks, Carol.
Thank you very much. Thanks, Chris, and thanks to everyone for attending today. And join us for the next Ask the Nurse. And I'm sure that you're all receiving, in addition to that, our other events for communities and professionals. And it's nice to see some of you on here who follow us ongoing and support us, and we appreciate that very much. So just remember, we're here to help. We're here as an advocate. We can assist you with information and resources that you need anytime. And again, thanks for coming on today, and have a wonderful and productive day.
Thank you.
Thanks, everyone.